Okay, because it's a fellows course, I would like to start slightly the basics so that you can understand it better while showing the cases. So, what's the rationale for using this IVAS? So, you have multiple limitations of just conventional angiography. You either underestimate or overestimate the lesion, poor inter-observer variability, low resolution, less sensitive to assess plaque burden. It's a two-dimensional structure, images the lumen and not the vessel wall, and QCA measurements are prone to magnification errors. The advantage of imaging is that especially the IVAS is got precise quantification of disease and extent of severity, good inter and intra-observer correlation, high resolution. It's able to assess the plaque and 360-degree imaging of the and actual sizing of the vessel walls. So now it has come to the class 2A indication for intermediate type of disease and for cardiac transplantation, prior to cardiac transplantation, and to understanding the mechanism of ISR. And for especially for the left main coronary artery stenting, we have got class 2B evidence. So how do we interpret these images? So as soon as you look at the angiography, you should look at some of the few important things. Look at the proximal distal reference segment. Proximal reference is within the 10 millimeters of the maximum stenosis, and distal reference the site with largest luminal distal to a stenosis, but within the same segment, usually within 10 mm. And you should look for the normal branches, veins, and the pericardium. So it's like this, a trilaminar image. You can see you have the intima, media, and adventitia. Middle layer is the media, which is less echogenic than the intima. The outer layer is the adventitia or periodontal tissue. It's relatively echogenic compared to the media. So it's like this. Look at the as soon as you take them, look at any branch vessels like this. And calcium, you have acoustic shading due to the calcium. So after that, what type plaque characterization, what type of plaque it is, whether it's a soft plaque is like hypoechoic compared to the adventitia. So it has got a high lipid content, so it can be concentric plaque or eccentric plaque. Again, the fibrous plaque, its echogenicity as compared to the adventitia, it rarely produces acoustic shading, and this is the most common type of plaque. So the other thing is the fibrocalcific plaque, you have a hyperechoic as compared to adventitia, you have acoustic shadowing, and depending on the degree you can amount the calcification. And thrombus, it's an echolucent or variable in grayscale appearance. It's usually layered, lobulated, or pedunculated. You can see the microchannels. Diagnosis of thrombus is just on IVAS is usually it's a presumptive diagnosis. And the next thing is the dissection. You have intimal dissection, medial, adventitial, intramural, or intestine dissection. Usually, if you get a 3-layer appearance, true lumen with 3-layer appearance, branches communicate with the lumen. In the false lumen, not all layers are present, and branches do not communicate with the lumen. And the plaque rupture, you have a plaque here like this, and you have a rupture in this region. This is central portion of the fiber, this lipid core, and this is the fibrous cap towards the lumen. So this is a plaque rupture. And the intramural hematoma, you have a accumulation of blood space within the medial space. You have displacement of the internal elastic membrane and external elastic membrane. You can see the dark say in between the medial space. And the myocardial bridge, which we routinely see, you have a white arrow points are like a half moon like crescent shaped appearance, both in which appears even during systole. So what is the other quantitative imaging? Whenever you look like the measurements are given MLD, minimal lumen diameter, maximum lumen diameter, and this cross sectional areas. And these are some of the things which you look for, like the proximal reference, distal reference, largest reference, and average reference. So as I told you, you can calculate the eccentricity, area of stenosis, and plaque burden. And the most important, one of the important thing is this area is the remodeling index, whether it's more than 1.05, negative if it is less than 0.95, and no remodeling if it is in between that. So look at this, you have a proximal reference like this, it's a negative or constrictive remodeling, and this is the distal reference. In the second example, you have a large lumen, which is a positive remodeling or expansive remodeling. And this is the clinical application of that. If you have a IVAS MLA diameter less than 2.7 to 4, it corresponds to the coronary flow reserve less than 2 and 0.75 to 0.8 FFR For the left main, 4.8 to 6 mm square with coronary flow reserve less than 2. So look at some of the artifacts. You should remember some non-uniform rotational distortion, ring down artifact, and the blood speckle artifacts, and the guide wire artifact. These are some of the artifacts which you should keep in mind while doing the IVUS. With this basics of IVUS imaging, we'll go to the case example. So this is a 40-year-old male patient who is a smoker, acute anterior MI with an ejection fraction of 45%. So this is like this. You can see here there is a proximal discrete medullary lesion. So left dominant circulation with L6 also diseased, and taken imaging from LAD. So you can see here there is a mixed type of plaque here with some evidence of plaque rupture, which is in this portion, and you have a branch which is coming here, this region. So the other thing is both the Volcano has the virtual histology and the Boston Scientific eye mapping, which characterizes the tissues. So if you have a plaque thickness more than 600 in continuous 3 frames with more than 40% plaque burden, if you have a confident necrotic core, then it, and based on OCT, if you have fibrous capillary thickness of less than 65, if it yes, and if you have dense calcium more than 10, if there is a dense calcium, it goes into calcified thin cap fibroatheoma, otherwise it's a thin cap fibroatheoma. This is thin cap fibroatheoma which will qualify for the vulnerable plaque. So in this case, particular case, the previous case, you can see here, it has got a color coding classification. You have fibrous, which is green, fibrofatty, which is with some component of greenish yellow, and a red, which is a necrotic core, and white, which is a dense calcium. So in this particular case, we have if you come to the proximal, you have more than 10% necrotic core, but there is no thin cap fibroatheoma as per IVUS, because you should have a necrotic core more than 10% abutting to the lumen without any underlying over this there should not be any fibrous tissue with more than 40% plaque burden. So this case is only thick cap fibroatheoma. So the post runs of IVUS into LAD, you can see here there is a good luminal expansion. If you get a perfect circle, it means that you have well expanded, otherwise you will get a eccentric type of pattern of expansion. So you should have at least luminal diameter in any vessel. If you get more than 4 in a medium sized vessel, the long term results are expected to be good. So that's the final angiographic result. So the second case is a 35-year-old male patient who was chest pain for last 6 hours. We came in cardiogenic shock, ST elevation MI with low ejection fraction. He was put on inotropes. So IVUS helps in looking at the side branches and helping in the guiding of the strategy. You have ostial LAD cutoff with some thrombus, and this is the RCA. So after crossing with the fielder XT wire, you can see here the IVUS imaging. Look at very closely on the left, this third way, there is a large diagonal coming which is not visualized on angiography. There is a large diagonal with some amount of thrombus. There is a significant plaque burden extending up to the just the distal left main. So again, I was pulled back from the diagonal. So you can see here there is a ostial to proximal, there is a mild, there is a disease, but it's a focal type of disease. So there's a large branch diagonal which was diagnosed with not even angiography. Then 2 wires were placed after dilating the proximal LAD, and just wanted to keep it open, but unfortunately there was a dissection in diagonal, so it was converted into 2 stent technique. So after finishing the procedure, IVUS of LAD was taken. You can see there is a good luminal expansion with a you get a MLA of more than 10 in the ostial LAD. Then I was pulled back from the diagonal. The most important thing here is the expansion of the ostium in the side branch bifurcation. In this particular case, you can see we have got well expanded ostium of the diagonal with a good perfect circle-like appearance. So that's the TIMI3 flow which you achieved in this patient. So you should achieve a very good ostial diameter of the diagonal branches. So the third case is a very late stent thrombosis, who is a 72-year-old male who is a diabetic, acute inferior wall MI, post-PCI to BMS in 2000, that's almost 2 decades of the first BMS implantation. So that's the angiogram. So the imaging helps in identification of the pathogenesis and what's the mechanism of underlying atherosclerosis, whether it's a neo-atherosclerosis or late stent malapposition, etc. So after aspiration of this, so you can see here there was a large thrombus we could retrieve. Performing IVUS from distal stent edge, you can see here there is a distal stent ISR, and inside this there is intimal hyperplasia. This looks like a stent slight under expansion in the first stent which was deployed, and in this there is a micro calcification just proximal to the stent head. So the evidence of some plaque rupture, the microcalcification, etc., will qualify for going as neo-atherosclerosis. So the PCI was performed in this patient, and post-PCI, you should see that again. Look at the previous prior imaging on this. You could get a large luminal diameter where second stents were implanted. So in the complex case scenarios, you can see the left main we have 46-year-old male patient was detected to have high blood sugars, anterior MI presented within 12 hours, ECG, ST elevation, and EF of 40 to 45%. And if you look at this angiogram, because of the diffuse disease of the nature of the disease, you will not be able to identify clearly what is the vessel dimension or sizes, because sometimes you can have a stenosis and positive remodeling, it would identify angiography, it would like a normal artery. Look at this, there is extensive disease involving from the left main to the distal LAD with a large diagonal which is coming up, and there is a ostial to proximal L6 disease. And prior to doing that, we have some IVUS classification for understanding the left main bifurcation plaque. It's like this in whether it's extend to the left main or the side branches like LAD, L6. So if you have a disease in the left main, you should understand that 90% of the time it tends to cross into the LAD. Isolated ostial LAD seen is only 3%, and isolated L6, distal L6 to L6 is seen in only 1% of the cases. So meaning that if you have distal left main, you should also identify that there would be some disease extending to the ostial LAD. So after placing the wires, pull back from LAD to left main was taken. You can see here, although the left main in our angiography was looking intermediate type, you can see there is a significant plaque burden in this distal left main, and here you have a MLD of 2.35 and MLA of 5 and 5.94. So if you have left main MLA of less than 4.5 to 6, it corresponds to an FFR of 0.75 to 0.8. So pull back from diagonal, you have osteoproximal disease in the diagonal with some amount of calcifications. Here you can see the speckled calcification, and you have some arch of calcium with acoustic shadowing, and runs from LCX shows there is a significant plaque burden in the ostial to proximal region, and this is the diagonal which is coming up. Oh, sorry, that's the LAD which is coming up. So after placing the 3 wires, he underwent a PCI to LAD D1 step crush technique, and after that he went a PCI to left main to LAD with again a 2 stent technique. So after high pressure balloon dilatations, and this is the angiography of that, and I was doing in the left main should achieve a values of like this MLA minimum lumen areas of 5 in L6 ostium, LAD ostium 6, and 7 in the polygon of confluence, and LM proximal 8. So this is what is expected if you do a left main bifurcation stenting in this area. So taking a pullback from LAD to LM, so you should achieve good luminal diameter. So in the coming proximal to the ostial LAD, you have a 3.32 and 8.89, close to 9 mm, and distal left main there is slight eccentricity, and here on the left main it is close to 14. So pull back from diagonal, again look at the ostia of the diagonal, you have a really good expansion 2.97 with an MLA of 7.87, and pull back from LCX, again it shows a value of 5.13 and 5.5. So that's the final angiogram, which you see the patient underwent a LAD D1 bifurcation and left main bifurcation simultaneously in a patient of ACS. So the last and final case will be in a complex disease. We know that usage of less stents would be better and provisional stenting would be a better option. But before doing that, we should try to identify the extent of disease and plaque in the ostium of the branches. Here is a 38-year-old female patient, diabetes, hypertension, came with NSTMI and EFO 45%. It's like this. You can see here, say trifurcation disease, left main disease extending to LAD, ostial LAD. It's like this. So pull back from LAD to left main. So you have a disease in the LAD and it's a soft plaque, and this is the left main, which is a soft plaque again, and pullbacks from the ramus. You can see there is only mild disease, and again from pullback from LCX. So there is only mild disease at the ostium. So we can go for the strategy. We can go for a single stent strategy and see what happens after that. So this patient went under single provisional stenting from left main to LAD, and this is the IVAS run. There was no pinching of the other side branches, and you could get a good luminal areas. So this is the initial angiogram post PCI, and this is the follow-up angiogram after 1 year. You can see this, the branches are widely patent. So what is the clinical application of IVAS? So stent underexpansion is the most important cause of DS failure. A minimal stent area of less than 5.0 in the first generation DES and less than 4 in the new generation DES are predictors of thrombosis. It prevents late stent thrombosis as with data from main compare and IVAS Tronco ICP Spanish study, and it also limits the use of the contrast used from the Mozart study. So with this, we found that IVAS is useful in routine practice, especially the complex case scenarios, and it should be used as and when possible when in doing a complex PCI. Thank you for your kind attention.
What are the exclusive indications you think of for IVAS in era of OCT?
Yeah, I think it's not whether IVAS or OCT which is better or not. It's actually we have to gain maximum whatever imaging you're doing. But if you want to look at the morphology or characteristics of the plaque, so the IVAS OCT because of the higher resolution, you tend to see better, like the mechanism, like the stent thrombosis. You can see the mechanism of what is the mechanism of stent thrombosis, or what is the pattern of plaque, whether it's a plaque rupture, erosion, calcified nodules, other morphology. So if you want to look at the morphology of characteristics of plaque and this thing, OCT will be a better modality, but it's not, we don't have much data for OCT, we have got robust data with IVAS. But I think whatever bit you should use, whatever imaging which is available. And for OCT, we should understand that we should need clear field, we should clear the blood. So especially in the ostial lesions and the of left main or this thing, you will not be able to clear the dye, or if the vessel is more than 4, you will not be able to do good imaging with the OCT. But with now coming with like pressure injector, Dexter and all, we are still able to do with good imaging even with OCT. But the IVAS is only thing, we need not have to use any dye, just put in a catheter, you just wait and you get a very good imaging. So it's not the imaging which is better or not, but we should use whatever imaging which we are available at the time.
Okay, thank you very much, moderators. So the purpose of this session is to take you through a OCT-guided PCI step by step according to the Illumian 3 protocol and now the Illumian 4 protocol. So here's the diagnostic angiography for this patient. There's at least moderate right coronary, a complex bifurcation lesion, and then there's a relatively more straightforward mid-LAD lesion where the patient has anterior ischemia based on a positive functional study. So I went through this on a number of occasions yesterday, and that is how exactly we want to use the OCT step by step. Pre-intervention, we're interested in determining what is the plaque composition and identifying the reference segments, and then choosing our stent size. After that, we want to deploy the stent from the normal to normal tissue and determine the expansion. And then finally, we want to look for post-procedural complications such as edge problems and major malapposition. This is the Illumian 3 protocol on how to use OCT. You perform a pre-PCI OCT. Whether you need to use balloon pre-dilatation or even atherectomy to deliver your OCT catheter, it's okay, no problem. Once you've done that, you determine whether or not you can see the media or measure the external elastic laminal. OCT blood vessel sizing is done by the EEL, not by the lumen, largely due to the size discrepancies between IVUS and OCT, and also because angiography alone oversizes compared to OCT. Finally, once you've determined your reference segments, the EEL, if it can be measured, or the lumen, if there's absolutely no EEL measurable, the distance between the proximal and distal reference markers is exactly your stent size. So here's an example. Pre-PCI, we dilate with a 1.5 or 2.0 balloon to adequately visualize the distal reference if there's a luminal obstruction. One way to do this cost effectively is to predetermine what post-dilation balloon you are likely to use. So you can actually use your post-dilation balloon and inflate it to 1 or 2 atmospheres simply to make space for the OCT catheter. The stent sizing was described on the previous film. Then you implant your stent, and only at the point you next ask yourself is there any angiographic residual diameter stenosis in the stent? If there is, of course, you should perform post-dilation, but if there is not, only at the point where you would otherwise be removing your guide wires should you do a post-PCI OCT. Finally, you ask yourself, is the target minimal stent area achieved? If it is not achieved, you perform post-dilation. If it is achieved, the procedure is complete. So let's take our case. This is the patient with the anterior positive FFR. What do you want to know? We want to know what's the plaque composition, what are the reference segments, and choose the device size based on our pre-PCI OCT. So let's see, we start this case at 12:30. This is the pre-PCI OCT. And let me go through this with you step by step. So this is angiographic co-registration in real time. You click along the length of the vessel, and next what the OCT is going to do is look for the lens along the length of this vessel. Once the OCT finds the marker, it will ask you to determine whether or not you're happy with that. As soon as we've done that, we have this important feature called the automated measures. This is the CT scan of the coronary. We are now using the reference marker to find a segment of the artery where I feel comfortable performing a measurement. Now here I can measure the media to media, and so already I know that my proximal reference is 4.2 millimeters. Similarly, we find an area of the automated measures that looks fat. There's the lesion, and we see this part of the artery is completely normal. You can see all 3 layers. You can see the media and the adventitia throughout. And here you perform your length measurement from one side to the other. You can see the artery is 3.2 millimeters, and then you perform another contralateral or a perpendicular measurement, and already we know that our distal reference is 3, our proximal reference is 4, and the length between the 2 stents or the measures is 34 millimeters. So in this situation, I'd be asking for a 3.0 by 34 millimeter stent. Now we peruse along the length of this stent, or the segment we're going to stent, and we determine, is there anything in this that's going to preclude my stent from expanding? So let's see what we've done. We've done angiographic co-registration. We've identified and measured our proximal reference. We've identified and measured our distal reference. We've surveyed the plaque morphology, and we have determined exactly where our stent needs to land. This took 95 seconds. At this point, you implant your stent. So this is the stent going in the LAO caudal view in order to make sure that I don't cross into the circumflex. And then I determine, is there any angiographic residual stenosis? But when I looked at this angiogram, I thought, no, this looks adequately expanded. Let me move forward to the next step. So the next step here is to do a post-PCI OCT. And here what we want to do is now we want to know whether or not the stent is expanded. So now it's 12:43, it's 13 minutes later. Let's go through the steps. The first thing to do is turn on this stent rendering device. Once you've turned on the rendered stent, you can see now that the artery is painted in with the stent inside it. And this very important white bar tells you where the OCT can see the struts. So you take your marker just proximal to the white bar, and you take your other marker to the distal end of the white bar. Right away, the OCT tells you that this is the minimal stent area. This is the segment of underexpansion. And by spinning, you can actually see that there's an area of eccentricity that's not allowing the stent to expand. For the Illumian 3 protocol, what we do is we divide the stent into 2 halves. And the reason that we do that is because, of course, this is a 34 millimeter stent and there's natural vessel tapering. Again, you can see that there's a minimal stent area of 4.88 and there was a residual stenosis of 8.5%. We now move the proximal reference just outside the white bar and put the second marker right into the middle of the stent, and we measure the proximal expansion. We see that the yellow box, which is the minimal lumen area, is at the proximal reference, and therefore the residual area stenosis is only 5%, fully expanded proximally. Finally, we highlight our region of interest again, click on the MLA, and then click on our angiographic co-registration, and we know exactly where our high pressure balloon should be, and the balloon should not be inflated anywhere else. This is precision PCI. This took 90 seconds. Now we perform our post-dilation in an absolutely targeted manner. You'll see I'm away from the stent edge. I'm only post-dilating that segment of the artery that had underexpansion. Okay, now it's 12:55. You remember we started this case at 12:30. So this is our post-PCI OCT, and let's go through it again. First step, activate the stent rendering. Once we've activated the stent rendering, we highlight the stented vessel area of interest. Again, you do that by highlighting using this white bar, which is the OCT telling you where the stent struts are. Once we've highlighted this, we immediately have a sense of expansion because that area previously where the minimal lumen area was is now fully expanded. And you can see that the minimal lumen area is now at the distal edge of the stent. We measure our distal expansion, which actually shows that the minimal lumen area is at the distal reference. These numbers are matching and the residual stenosis is 0. If we go to the proximal vessel just to make sure that we haven't caused any damage from our previous balloon, we scroll backwards and see that in fact the proximal reference is also fully expanded because we are again at the proximal reference. This is a 100% expanded stent with one post-dilation targeted to the area of interest. 67 seconds. So that's the procedure complete. And that's the final angiogram. So the purpose of this is to really highlight for you that using OCT can be done extremely rapidly in your practice. The pre-PCI assessment took 95 seconds. The post-PCI took 90 seconds. And the final optimized assessment took 67 seconds, which was a 4 minutes and 20 seconds of optimization with less contrast, less radiation than you would have otherwise known because everything was performed in a targeted manner and there was absolutely no guessing throughout the procedure. Entire PCI procedure took 25 minutes. Thank you very much.
Sir, you have a lot of time.
If we have a
Speaker
lot of
is
time,
not
I
there.
can do another case.
You want to show another case?
It's up to you. Would you like?
Okay, sir. Yes.
Do you guys want to see another case?
Yeah.
Okay. Okay, so again, here's the algorithm, OCT stent sizing algorithm. We perform the pre-PCI OCT and we measure the EL at both the proximal and distal reference segments if possible. The EL be identified at the distal reference. All the measurements are made at the distal reference. And then if it is, we use the EEL or the media. If it's not, we use the lumen. And the reference stent, again, is decided by the OCT automation. Okay, so this is angiographic co-registration. You can see all you do is click along the length of the vessel. And now we've performed an angiographic co-registration. This is a patient who came in with a non-ST elevation MI. Again, what the OCT will do is it'll start to look for the lens along the length of, or area of interest. This typically takes between 15 to 30 seconds and is the longest part of programming. Once we've done, the next step for us is to identify the proximal and distal reference measures. So here what you can see when we start the case is that clearly there's a lesion in this area, but what we're trying to find is an area of the artery that is nice and fat. And so you can see here, this is a nice juicy part of the area, and you can see all the layers of the artery. So by performing the length measurement, we go from the media into the media, and then do another measurement from the media into the media, and this is our distal measurements. So I already know that I'm going to need a 3.0 millimeter stent. Proximally, the reason we make our measurement is because this will help us to determine what we need for the proximal reference for balloon dilation. Now, something very interesting here is I can't find any area where there's no plaque, right? There's no area that I can make a media to media measurement. So only in that situation, we use the lumen, and then we upsize. So here I'm going to make the measurement of the lumen. And the lumen is actually smaller than the distal reference, right? 2.17 millimeters. And that means that I'm going to have to post-dilate based on the angio after I implant my 3.0 stent. But you see the difference between lumen-guided and EEL-guided stenting. If we were to use the lumen, we put a very small stent here. Now we peruse through the plaque morphology, and question comes is there anything in this lesion that's going to preclude the expansion of the stent? There's the plaque rupture, there's the cause of the ACS, but critically there's no calcification. So already you know there is no need to spend money on a pre-dilation balloon. Just go now with the next stent move, which is the direct stenting. So let's review. The distal reference is 3.09 millimeters. We round it down to the nearest stent size, which is 3 millimeters. The distance from the distal reference to the proximal marker is 38 millimeters. You ask for a 3.0 by 38 stent. These are the measurements, 3.16 by 3.02. Proximally, we could only make a measurement from the lumen. So this information for us right now is completely useless. So now we need to use the post-PCI OCT to determine the proximal vessel expansion. Okay, next step, angiographic success. So let's take a look. Oh, sorry, there should be angiogram there. Then we do post-PCI OCT, and we determine whether or not there's a target MSA criteria is achieved. Okay, so same thing as we did first time. Angiographic co-registration, 2 clicks. And this, believe it or not, is the longest part of the entire procedure, is waiting for the co-reg. This can all be done extremely quickly. So the reason I keep showing you this is because I'm trying to get all the steps in your head. First step, rendered stent. Second step, look at the white bar. That's our stented segment of interest. Take your scroll bar, take it to the edge of the stent. Take your other scroll bar, we take it to the edge of the stent. Okay? So as soon as we line this up and we see the MLA, we see the MLAs at the distal reference. So in its entirety, this stent is fully expanded. Direct stenting, we knew the plaque was safe, we knew the morphology was safe, no need for balloon dilation, all automated. Now, when we divide the stent in half, again, we do this because it's a long stent, we see that the distal reference and the minimal stent area are same. So this segment of the artery is fully expanded. Now we do the same thing in the proximal half of the stent. There's the proximal marker. Divide the stent into half. And we see that, again, stent is fully expanded in the proximal segment. Now, what I'm doing now is I'm actually taking the markers outside of the edge of the stent. The reason I'm doing that is to determine whether there's any reference segment disease. Now you can see that the minimal lumen area at the reference segment is 4.9, but the vessel is tapering. Finally, I'm scrolling through the artery to make sure no significant malapposition or tissue protrusion. There's some tissue protrusion, but not significant here. And this white bar, if there's no red on it, this means the stent is fully opposed. So you don't even need to look through it. Okay, so distal reference, 0% residual stenosis. Proximal reference, 0% residual stenosis. Now, are the reference segments free of any disease or dissection? When we look at the distal reference 5 millimeters, there's no dissection and there's no reference segment disease. Do the same thing in the proximal reference. Proximal reference looks perfect, circular, no dissection, minimal lumen area 6.19, and that's it. Procedure is complete. Look, take 15 minutes. So these procedures are all guided by the computer. I like to call this computerized PCI. There's no human involvement in the decision-making process. Everything is decided by the computer, and as a result, it's not prone to human error. There's not a lot of judgment involved in this. Thank you very much.